Well, good afternoon, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, I am here with Chief Medical Officer of Regenix and Chief Medical Officer of the Centeno Clinic in Colorado, Dr. Chris Centeno. Great afternoon to you.
Good afternoon, Jason.
We have a great and very important topic to talk about today. It's something that has affected many over the years. The question we are asking today is, what is failed back syndrome? It is a broad category of things, but let's not belabor the point. Dr. Centeno, let's get right into what is failed back syndrome. What is it that people need to know about what that is exactly and how they know if they have it?
Yeah, failed back syndrome could be one of the most talked about medical diagnoses of all time when it comes to pain, meaning that we all know somebody who, whether it's somebody directly or we know somebody who knows somebody who's had back surgery and it didn't work. And, it's interesting that back surgery is one of the few things in medicine that has an entire subculture of it didn't work. And it actually has a medical term for it didn't work, and that's called failed back syndrome. It's like there was a movie a while back where the title of the movie was Broken Arrow, and they explained to the main guy that a broken arrow was a nuclear weapon that had gotten into the wrong hands. And the guy said something like, I don't know that I should be disturbed that a nuclear weapon has gotten into the wrong hands, or that you actually have a term for a nuclear weapon that's got hands. This is common enough that you came up with a term for it. So it's the same thing here. This is so common that we have a medical term for it called failed back syndrome. And it's a medical diagnosis. There are people that deal with failed back syndrome, super specialists that deal with it, et cetera. So it's basically back surgery that didn't work.
And so and how do you define, I guess, working? So, is it all or nothing, or help people understand, maybe I had back surgery, I felt some improvement for a period of time, and then it sort of went back to the way it was, which if they're going to improve is common for the way it would happen. Or is it really more of along the lines of, I went in for surgery and now it's worse? How do you know if it's failed? And if it's now a syndrome and not, just another step in the process of, what's next? Another surgery, more drugs, stem cells. How do they think about it?
Yeah. So these people generally fall into one of three categories. One is I had the surgery, it helped something, but now I have new problems. And that's very common, for example, with a fusion where you have adjacent segment disease. So the fused area feels better, but the area above and below the fusion begins to break down. Another category would be I had the procedure and I'm a lot worse. And that tends to be in the category of scarring around the nerve roots. That's called perineural fibrosis. Sometimes it's in the category of instability that's new since the surgery, where they've taken out parts and pieces of the facet joints and things are moving around too much. And then the third category is I had the surgery and, it didn't help my pain. I still have all the same pain I used to. And many times that's because there was never a correct diagnosis for the back problem to begin with. We looked at the bright, shiny object on the MRI, which was this disc right here. Aha, that has to be it. No testing was done to confirm that, other than someone did a quick physical exam. They looked at the MRI, and then they operate on that disc, and it turns out that's not what's even causing the pain, so the surgery did nothing. So those are the three categories that people generally fall into.
And I guess what I want people to understand is, how that thought process goes from the doctor's standpoint. So, let me actually first start off with, let's get with the science. What does the science say about these surgeries so people can make the right choice? And the point I want to make after that, which I'll sort of dig in now, is the surgeon doesn't necessarily have a lot of skin in the game, because the incentive is to, well, let's give it a try, because then I'll get paid for the surgery. Maybe it'll work, maybe it won't, but I walk away a winner regardless. Or How does that all work really from a doctor's standpoint, not just the consumer standpoint that they may not be thinking about?
Yeah, listen, when it comes to surgery, I always tell patients that surgery is damage to accomplish a goal. There's no way around that. You have to get to where you're going to operate in surgery, which is carving a hole. It could be a big hole, could be a small hole, but it's still a hole. And then you're doing some damage to the tissue. Maybe you're removing something, maybe you're trying to sew something back together. And so it's damage to accomplish a goal. So the first thing you need to understand about surgery is that. And if you look at surgery instead as, oh, it's like my mechanic, my car doesn't work. He goes in and puts a brand new part in, no harm, no foul. I'm going to drive out of there with a brand new car. Again, not what surgery does. That's not surgery. Surgery is damage to accomplish a goal, very different than getting your car repaired. And then I think you got to look at, what's the right surgery for me if I need one? And that's all about making sure that you do everything short of that damage to accomplish a goal before you actually pull the trigger on that surgery. And all too often, what we see is that patients are just given a limited option. Well, try some physical therapy. If that doesn't work, we'll do surgery. And what patients aren't doing, and what the physicians aren't doing either, is really looking at the spectrum of options that exist before surgery and trying all of those before they get to the point of damage to accomplish a goal, which is what surgery is.
And I think that's part of the interesting part. You mentioned both on the doctor's side, it's harder to teach people. On the consumer side, that means I got to do some work. It feels as if right now the momentum is, well, let the surgeon just give it a try. Then the patient, don't have to do anything. And it's in the surgeon's sort of court to fix it for me. And they get paid to do it. So that seems to be the agreement. But then let's go back to, what does the science really say about these surgeries? I mean, like you said, your analogy on the car situation is a great one, because I think that's how most people think about it. Well, if it's not the right part, then they'll just put in a different part. It's not a big deal. They'll send it back and get credit, and I'll drive out with a fixed car. But as you say, surgery is extremely different. No matter what, you're walking out with a hole and the risk of infection and the need to heal the hole, regardless of whatever else they did while they were inside and whatever potential mistakes or things they left in the body or wrong sides or all the other realities of surgery. What does the science and research sort of show us over time about how effective these things really are?
Yeah, so if you look at, what's really fascinating is we probably all know that the standard in medicine is a randomized controlled trial. That means that that's high-level research where one person was randomized to get treatment X, another person randomized to get treatment Y. Now, you might believe that we have tons of randomized controlled trials showing that, in this case, low back surgery is effective. You would be incredibly wrong. Couldn't be anything further from the truth. We have very few randomized controlled trials showing that back surgery is effective. In fact, we have many more showing that back surgery is no better than just physical therapy or not operating at all. So that's the first thing you need to understand. We don't have this high-level research that's sort of this gold standard in medicine for back surgery. We just don't. And when we have studies done like that, they generally show that it's no better than doing nothing. So it's incredibly important to recognize that. Now, that doesn't mean there aren't people that don't need surgery, but it's a really good ground floor understanding for you to have that this is not something with a lot of evidence. And we've got to be very, very careful who we choose to walk through that surgery door, because all too often there's no walking back out of that surgery door. It's a one-way door with one of those little things that you see in the hotels where you can only go through one way and not the other. So, who goes through that door needs to be carefully chosen.
There you go. Listen, we are talking about failed back surgery, what it is, how to know, how to avoid it, and how to know if you've been in one of those categories, if you've had back surgery. Couple just announcements. We'll move into taking questions. If you're watching and you've got questions, now's a great time to ask. And also, if you are interested in finding out more about Regenexx and Centeno Schultz, you can go to find out if you have coverage for any of these procedures covered by your employer by a brand new program. I shouldn't say brand new website for a program that's been around for quite a while at regenexcoverage.com. You can find out if your employer is now covering Regenexx procedures that you could get specifically at the Centeno Schultz clinic outside of Denver. Going into failed back surgery, we do have a question that was submitted in advance, so let's get to questions. Cindy Charlin asks, can you do anything for a lumbar fusion that has, it says called more pain than it fixed? I'm going to assume that was a typo that said created more pain than it fixed. What can you do with orthobiologics for failed back surgery?
Yeah, we see a lot of patients with failed back surgery, and in particular, a lot of fusion patients. So I'd say about a third to sometimes almost half of the patients that we see on a weekly basis in the clinic who have failed back surgery are patients with lumbar fusion. So what happens? What does that look like? As you know, or you may have read some things that I've posted, that fusion is where we take certain levels and we kind of bolt them together or make sure they don't move in some other way. And what that does is that causes the force to go above and below the fusion, and that can cause those levels to start to break down. So our goal in treating those patients is to treat those levels above and below the fusion. Sometimes we'll treat the joints, the ligaments, the nerves, all of those things. And the good news is we have a high rate of success with those patients. The bad news is that because the fusion is there and it continues to overload above and below, those are patients that we're probably going to have to see on an ongoing basis every couple of years to keep those levels as healthy as we can using those orthobiologic injections.
And it's essential to find out if you can get help. We've got more questions coming on in. If you're watching and you have questions and you want to know if you've had failed back surgery, if help is available, you should reach out and let us know. And if you'd like to find out if you can avoid surgery so you don't be the broken arrow of surgery, and you avoid that concept altogether, that's really the best advice. One of the things I say as a chiropractor that we're most helpful in helping people is to avoid the problems they never knew they would have had if they didn't get the care in advance anyway. And that's really what it's all about. Doc, I guess you mentioned lumbar fusions. Let's just go through a list of different back diagnoses that somebody might have that may make them eligible to become a surgical candidate, so they can go, well, nobody's mentioned lumbar fusion to me, but they've mentioned blank. This is a wide category of different diagnoses, as you've said, often misdiagnosed. What are some of the key words or diagnoses that somebody might have heard early on that should be a flag for them to pay attention and go, wait a minute, that might be me?
Yeah, very good question. So a herniated disc obviously is one of them. We'll frequently use a platelet lysate epidural injection with those patients. So that's the platelet's own growth factors. Other things that you might have been told you need are things like frequency ablation. That's where the doctor goes in and kills the nerves that are taking pain from painful facet joints in the neck or the back. Again, we can usually help those patients avoid that ablative or destructive technique by injecting their own high-dose platelets into those joints and sometimes stem cells. A disc bulge that's not going away, another thing that we commonly treat. A tear in the disc, which is another thing we commonly treat as well. So lots of different things can be treated to help patients avoid surgery. And the good news is for many of those things, the success rates are quite high. That doesn't mean that any one of them is perfect, and sometimes the patient will end up getting surgery anyway. Another big one for us is lumbar stenosis. So that's where the nerves in the central canal of the spine tend to get pinched when the person is standing and tend to get relieved when the person is sitting. and we can usually help those patients avoid surgery as well.
Let's talk about how somebody should be thinking about when it's time to take a different action. My understanding is musculoskeletal conditions, primarily low back pain, are the #1 cause of disability in America today. It's the most popular issue people experience. We've done many episodes in the past that talk about what's become normal, which is just to simply, take your NSAIDs or whatever prescription you have, because hey, when I take it, I do feel better. And they seem to have been convinced, unfortunately, that that's a reasonable form of managing their pain until they can't any longer. So help us think through, if I've got a disc bulge and I'm living on basically medications to manage the pain, what are the consequences of staying on that road versus their other options? So, let's talk, many people think they don't know what they don't know. They're like, I take the drugs, it works, I hope it gets better. Doing something different is time, energy, money. I don't know if it'll work, and I don't know how long it'll take before I heal. What do people need to know about, stopping, paying attention to their existing regime? If they're living on these medications, you and I both know that they're just kicking the can down the road and letting the fire get worse over time. It's just how it works. What do people need to hear in order to realize that just managing your pain through drugs is not a recipe or prescription for success? And when the right time is to go, this is enough already, I should take a different pathway here.
Yeah, a good point. I think the first thing we need to understand about the most common type of over-the-counter pain medications, which would be non-steroidal anti-inflammatory drugs like Motrin, Aleve, Advil, those sorts of things. All of those dramatically increase your risk for a sudden death heart attack or a sudden death stroke. So very important to know that they're not good medications to take long term. And then the other thing that we see is that people get addicted to these things. They may not have the same physical addiction like they do to narcotics, but what we find is that it usually starts where you hurt your back and you pop a couple of these and you feel kind of better and that episode goes away, but then another one comes on and you take them some more. And then you start to notice that if you take these before exercise, you can do more. So you start doing it that way. And before you know, you're taking them all the time, because if we don't take them, you just don't feel good. You feel really, really achy and sore every place. So that is not the way to manage these types of problems. At some point in there, after step one, where you've taken some non-steroidal anti-inflammatory drugs that seem to go away, and then it came back, that's where you need to act. That's where you need to start to say, something's going on. I better get this checked out. And would recommend that you get it checked out by a Regenexx provider, or if you're in Colorado at Centeno Clinic, simply because at the end of the day, you need a doctor who's going to take the time to look at this with a different pair of eyes, not with that pair of eyes that says this is surgery or not, but that says you might need a surgery, you might need 5 other things in here, or just physical therapy should take care of this. So that's not binary, that looks at the whole person.
If somebody does, oftentimes there's an event that precipitates, oh, I got this back pain because I bent over and picked up the newspaper, if you still subscribe to one, or, whatever normal thing you did. I woke up and it was achy, or I'm a weekend warrior, I played sports. There's an event that sometimes precipitates the pain. If it's more of an acute injury, how much time should people expect for some sort of event before they should be healing from most things most of the time? So it goes from, I guess, what we would define as acute into a chronic issue that doesn't seem to be going away. What's that time with balance kind of thing for people to go, this has just been too long. I wanted to give it some time to heal. I trust my body. Maybe it'll just go away. I don't want to overreact to it. But how long should they wait before it becomes something they go, I should be getting this checked out?
Well, I'm going to give you my own personal example. So last week, I ended up doing something stupid, hurt my back. And what did I do? I took the first day, Tylenol 2 times, and I don't take those medications. So they work well on me. One of the problems we see with those medications is that if you take them all the time, like any medication, they're not going to work as well. I maybe take that stuff once a year. So it does fine for me. I was able to function. I wasn't perfect. The next day I took Tylenol only once. The next day I didn't take it at all. And it really took about almost a week for that to work its way out. Now things are back to normal right now. So I'm pretty good. But I have to tell you, if by this Monday, so that would have been almost a week, I didn't really start to feel different, I was going to get in and get some injections done, probably a platelet lysate epidural. So that's how I would do it for me. Now, you might take other steps. You might say, well, I don't have as easy access to that stuff, so I'll try some physical therapy, or I'll go back to my chiropractor. He seems to be able to figure this out. And those are all great choices. But if you're entering that couple week mark and it's just not getting better and nothing's really helping, or if you're up against that 1 month mark, that's really when you should start to say, hey, I got to do something different. I don't want to get addicted to these over-the-counter pain meds. And for whatever reason, this time, whatever therapy usually works isn't working. So that means this is probably in a different category. I got to get it checked out.
That's great advice. And the thing for people to realize about taking these medications is it's like a fire alarm where all you're really doing is cutting the wires to the alarm. The fire is still blazing. And in fact, when you take medications and then continue to be active as you were, so you can be active, you're actually fueling the fire. And that becomes a problem because now you don't have a fire alarm to let you know how bad it really
Oh,
is, and the fire
and,
rages. Please go.
and I felt that. I could tell you that had I just decided to take Tylenol before I did any type of exercise, I would have felt great. I would have paid for it that night, felt taking Tylenol again, felt great, paid for it. It would have been a vicious circle. So at some point, quickly, I had to say, you know what? I'm not going to take this stuff anymore. I'm going to see where it is. And I did some very slow, gentle workouts, listening to my body. So very, very important that you understand that you've got to not get into that trap of taking medications just to feel good. And as you said, not paying attention to those signals.
Exactly. All right. We've got Sabina in the last few minutes that we have. Loyal viewer. Hi, Sabina. Always a pleasure to have you viewing and joining us. She says, hi, Dr. Centeno. Had one round of cells injected into my hip with no relief. Also had a capsular distension prior. Aside of a major labral tear and large bone cysts, I'm also diagnosed with dysplasia and impingement. About 50% of the ball out of socket. It is really compromising all other joints in my body mechanically, but I refuse to do a PAO. Dumb surgery, in my opinion. Would doing another round of cells potentially solve the problem? Thank you.
Yeah, I'd have to see your MRIs to really know. But if you have a bone cyst already, then you're really not a candidate for a PAO surgery, so just so that you understand that. So that people understand what we're talking about. There is a surgery called a PAO where they basically saw off a portion of your pelvis, disconnect it from your body, rotate it so that a joint that doesn't have enough covering, hip joint, gets some coverage, and then they will go ahead and bolt it all back together. The biggest problem with the surgery that we've seen is we've seen a few patients through the years where it never healed. So they are literally living with their whole leg at the pelvis disarticulated from the rest of their body. And these people obviously are completely non-functional, bedridden, etc. So that's the biggest problem with PAO surgery is it's more invasive than the hip replacement that it seeks to get rid of. And that just makes no common sense. Why would you replace a less invasive surgery with a more invasive surgery? It just doesn't make any sense. So we're not a big fan of PAO surgery. Now, having said that, if you've already got osteoarthritis in the joint, meaning, and that's usually when you get bone cysts, PAO surgery is usually not recommended. to whether or not you need another treatment for that, or you might need a different treatment for that. I'd have to look at your chart and see what's going on. One option would be injecting the bone itself versus just the joint. But again, I'd need to look at your images to see if that's appropriate. But just realize that PAO surgery, very, very big procedure. And I've seen several patients now who are literally disabled for life because they can't get it to heal. And that means that their pelvis disarticulates from the rest of their body on that side. So their leg is no longer connected to their core through bone.
It hurts just thinking about it.
This is one where I have to shake my head. I look at that surgery and say, what are you guys doing? Just wait till the hip goes out and replace the hip. I don't know why you're disarticulating these people's pelvises, because if that goes bad, it goes really bad.
I guess sort of concluding for the half hour today, we are living in the bizarro world. Sometimes the cure is worse than the disease. As a chiropractor, I just always baffles my mind how people say, well, there's a few that say, I'm scared to go to a chiropractor, I'm going to have surgery. What? Have you been to a surgical suite? You'd rather have somebody cut you open with knives and, than gentle. It is the bizarro world. Again, same thing with, living on medications versus healing and correcting the cause. It just makes zero sense. But we do just have to recognize and understand that most of the information most of us get is from the mainstream news and the mainstream media. And if you wonder if any of that is accurate or inaccurate, I just invite you to take a look at how many pharmaceutical advertisements you see throughout the day in everything you're watching and reading, and just question for a moment, is it even possible that some of the information you have learned for a little while has been sponsored by pharma and has driven you to what is best for the pharmaceutical industry, the medical device industry, the medical industry, and not necessarily what's most conservative and going to lead to the greatest outcomes for people as a whole. That is just an unfortunate reality of our healthcare system today that I know Dr. Centeno and I are extremely committed to making change in, by helping you take your power back, by understanding how to ask the right questions, by understanding how to think about these things. When you understand that cutting the wires to an alarm system would make zero sense if there was a fire in your house, you may understand that just simply numbing your body to the damage that's going on day in and day out is equally illogical. That's the end of our program for today. Any closing comments, Dr. Centeno?
Yeah, just to wrap it up on failed back syndrome, at the end of the day, just realize that it's crazy that we have an entire term and subspecialty focused on the failure of back surgery. And at the end of the day, just do your homework so that you're not one of those failed back syndrome people, and you can intervene and make sure you really need that surgery, because all surgery is damage to accomplish a goal.
There we go. That's our program for today. Listen, if you are suffering from pain, low back pain, or any type of orthopedic joint pain, or if you know someone, live someone, work with someone, are related to someone who is just sick and tired of being sick and tired of dealing with their pain, and if you're tired of hearing it and they're tired of feeling it, maybe this is no accident that you may be listening to this program. And now is the time I would invite you to either check out regenxcoverage.com to find out if you work for one of the employers, one of the really smart employers. There's almost 8 million lives covered here in the United States these days. You may be one of them. You can check it out. And if you don't work for an employer that you know you wouldn't necessarily have coverage for, then why don't you reach out to the Centeno Schultz Clinic or somebody on the Regenx network near you and just get some information. Find out if healing is available for you so you don't have to run the risks of becoming a drug addict, or in this case, run the risk of failed back surgery. Not a good thing. So we are at your service. We're here for you. We're here Mondays and Fridays. Mondays here on the Centeno Schultz page. On Fridays, we broadcast 12 Pacific time, 1 p.m. Mountain time on the Regenx Facebook page. Until Friday, on behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. You've been watching You've Got the Power, because you do. Please take it. Keep on learning. Keep on asking. We hope to see you in one of our clinics one of these days very soon. Stay well, be kind. Thank you for sharing this video with those of you that need help. Have a great day, everyone.